Good morning or good afternoon if you're on the if you're in the Eastern time zone, and good morning to those on the West Coast and in other places around the world. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. Many of you know who we are. We have over 300 sign up for this event today. Doctors Ruben Mesa, who is with us right now. Hello, Dr. Mesa.
Hello.
My pal and our advisor and frequent speaker at these programs, and Dr. Naveen Pemmaraju will be joining us as well. So we have two Texans here today, and we're freezing in Michigan. It was 1 degree, I think, this morning, and I think it's up to 18 or something like that. And so we'll wait for Dr. Naveen to join us. And but in the meantime, if you have any questions, please post them in the chat area, and we will be happy to ask those of these two wonderful people. And also next week on February 3rd, we'll be hosting a program all about transplants. And so what I'd like to do now is just have Dr. Mesa, I know you want to share a slide with us.
I'll share the slide in a moment. Maybe to begin with, let me set the stage.
Okay.
So first, as we talk about clinical trials, we probably all have different ideas as to what's a clinical trial, what's its role, what's involved with me as a patient. So first, in medicine, whenever we're testing an idea, a new therapy, a different approach, we do clinical trials to study, to see whether the new intervention, whether that's a medicine, an infusion, a surgery, whatever that is, to see, is it effective? Does it do what we want it to do? And is it safe? Does it have side effects? What are the negatives? We frequently will ask, is it better than the therapies that we have? So that is a critical piece, because people say, well, I want to be on this drug, can I try it? So a clinical trial is really designed to see, is a therapy safe, effective, and is it better than what we have currently? So certainly the base of what our current options are is critical as we try to determine what clinical trials make sense, what are areas of need, where are areas where new therapies are being developed. Now, as we speak of clinical trials, there are many types, but a few kind of key things. One, in a clinical trial, you as the patient are always in the driver's seat, meaning although you sign typically long forms that are called informed consent forms, these are forms that are meant to inform you about what occurs in the study, information about who to contact, information about the medicine, what to expect in terms of the schedule. What it is not is a contract. So although it looks like sometimes like you're signing a mortgage, what I try to share with my patients, it's not a commitment, meaning you are not committed to have to remain on the trial any longer than you so choose. An individual can sign this form and choose not to participate in the study or take one tablet of a medicine and change their mind. You are completely in the driver's seat. A clinical trial is just a very structured way of really evaluating an option or a therapy. There are different types of trials. They typically start with what we call phase 1 trials. These are trials where we have a new medicine, we have an idea that it may be beneficial from testing that we can do before it's tested in people or patients. And the purpose of the phase 1 trials is, again, to get a sense of the safety, the right dose, the frequency to take the medication. A phase 2 study, which tend to be many of the studies that patients participate in, are typically studies with anywhere from 10 to usually no more than 50 patients, all of whom are receiving a therapy. And we try to understand the safety and the effectiveness of that respective treatment. A phase 3 study tend to be the largest studies. These typically are anywhere from 100 to 400 patients as we think about MPN studies. But in other situations, it can be very large. You know, in the COVID vaccine studies, there were sometimes tens of thousands of patients. But with MPN trials, usually more modest in the numbers. Phase 3 trials tend to be where we have one drug or one option that's compared against something else. It may be the current standard of care. It may be a different option or some sort of comparator. Sometimes a comparator may include something that is known as a placebo, which is an option that is like a sugar pill. This tends to be the exception nowadays, but can be the case. More often, the comparator is the current standard of care or best alternative therapy, meaning the alternative is the physician or healthcare provider is able to prescribe whatever one needs. So that's just a little bit of a base background. What's a trial? You're in the driver's seat. The informed consent process is really meant to inform you and a bit regarding the phases. And I see Dr. Pemmaraju is joining us. Welcome, Naveen.
Ruben, how are you? Ann, how are you? So nice to meet you guys.
So glad you are able to join us. So Ruben just gave kind of a brief summary of phase 1, phase 2, phase 3. Nice. And I said, welcome to you two Texans. And I can only imagine, what is the temperature there, if you don't mind my throwing that question out there?
You know, it's colder than normal, so I think today will only be 60. So everyone has their sweaters, you know, the puffy coats, the
chains on their tires.
but fortunately, we get back in the 70s this weekend because people here really don't like it to be cold.
Yeah, well, we have space heaters and fireplaces and the heat jacked up, but it's horrible here. But anyway, so moving right along, Dr. Pemmaraju, would you like to share anything about, you know, just the trials, just in general, your and the reason, by the way, the reason why I'm doing this is because when we were at ASH, we heard about a lot of trials that we knew nothing about. And I think what's happened is there are lots of trials going on at different institutions that have nothing to do with, you know, some of the bigger partners that we have and commercial partners and so on. And so would you, you know, are there some things that you would like to share? And Ruben, go ahead. I can see you want to say something.
Well, maybe just to frame it a bit, because I've thought a little bit, you know, it's a big task, you know, what are the trials in MPNs? Right. You know, let's take it, you know, one disease at a time. Let's do ET, PV, and then MF. You know, and I will make a couple comments in the Naveen that chime in as well regarding, you know, what is our current base in that disease? Right. Because I don't think I can emphasize enough. A clinical trial is about trying to extend beyond what we currently have. So what we have is really relevant in terms of, you know, where does a trial fit in? Because I'll have patients who come in who, let's say, are on ET and are doing beautifully on hydroxyurea and say, you know, I'd like to be on a trial. And, you know, a trial of another therapy may or may not make sense because they're doing beautifully on this medication. You know, so where we start is a bit important. And then, you know, the majority of the time will be, there's the most trials in MF, in part because MF is frequently the most problematic or most difficult to treat. Right. So maybe, Naveen, why don't we just give folks just a a thumbnail,
Right.
what is our base in ET? Because as we think about new therapies, it really is, okay, well, how could that be better? So what is our base in ET?
Yeah, well, that's great, Ruben and Ann. I think that's right. We can't know where we're going until we know where we came from and where we are. And so as Ruben was mentioning, in essential thrombocytosis, or ET, in general, we had always thought about this hematologic or blood cancer as more indolent, slow growing, but patients still have problems, disease-related issues, and decreased quality of life. So Ruben's group was really the first group to show that despite the blood counts, quote unquote, being normal, quote unquote, people can still have symptoms that seem out of proportion to what's on the lab reports. This is a very important way to look at it. And then also our patients with ET can have blood clots, bleeding, and then unfortunately a very small percentage of patients, but sizable, can go on to myelofibrosis and even acute leukemia. So, controlling the ET and the symptoms and the thrombosis or blood clots is important. So what we have, as Ruben mentioned, we have the hydroxyurea agent that's been around for decades. That is meant to not only control the blood counts, but can it also help to help some of these other aspects? So we have that. That's a pill form. Many of our viewers out there know about it. Number two, what's been very helpful in the clinic, particularly for some young patients and people who need different therapies, is interferon based. That's also been around for decades. Now in the United States, we've been using the pegylated interferon known as Pegasus. And then, of course, our European colleagues have now pioneered the ropeg interferon Bezremi, which is currently only approved for polycythemia vera, but of course, being looked at for ET. And then finally, there is the older medicine known as anagrelide, which again, this medicine has been around for decades, maybe helps with some limited aspect of the platelets, but certainly has a little bit more to be desired in terms of the overall. So really a limited, but trial and tested kind of armamentarium for what we've had in ET. And then of course, as Ruben is saying, that sets you up to understand the couple of clinical trials, right? So you have this Bezremi or ropeg interferon, which is being tested. And then of course you have other new agents, such as, Ruben, the LSD1 inhibitors, which are a brand new class. Ruben, so that's kind of the landscape of ET.
Well, that's incredibly helpful, because I think that really helps to establish, what is that base? So there's kind of the short term, and we'll get around to what may come in the longer term. But in the short term, trials that people are eligible for kind of right now. So first, as you mentioned, interferon, of which we largely have used pegylated interferon alpha 2A, frequently what we call kind of off-label, meaning it's not approved
right
for that disease. It's it's still being manufactured, but that's a complex discussion in and of itself in terms of the supply of Pegasus and who's making it and how long they'll make it and other things. But many find the challenge of getting insurance company approval or other things as it relates to receiving that. So we now have ropeg interferon approved in PVera. It has not had, up to date, large studies in ET. So there is a study that is being led both at MD Anderson by Serge Verstapchuk, Naveen and colleagues there, and myself. It's a global study called the Surpass ET study. Now, like clinical trials, one of the things with clinical trials that I know is a frustration both for patients and for treating physicians alike is that they don't include everyone. The clinical trials,
right
for many reasons, sometimes are really for a subset of patients because they're trying to prove a very specific thing for the FDA. So, for example, this particular study is for individuals that have very active ET. They have failed hydroxyurea. So the trial is a second-line trial. And it is for individuals that have very active disease, meaning they also have an elevated white blood cell count. And I recognize that this describes just a subset of patients with ET. They are randomized between the ropegulated interferon, and they have to compare it against something else, because the FDA says, well, if you want this drug to be approved, if you want people to be paying for it, if you want patients to be taking the drug, you got to prove that it's better than what we have. And the approved drug we have in ET is anagrelide. The two approved drugs are Hydrea or anagrelide. So there's really no escaping, have to prove that it's better than anagrelide. So the patients are randomized, I think in a 2-to-1 fashion, ropeg versus anagrelide. And then at some point we'll be able to cross over to the ropeg if they were randomized to the anagrelide. So that's an important study. It's ongoing. It's at several sites in the US, certainly a couple in Texas, many in Asia and others. But that's one key study, and it's critical both for individuals that participate, but also it will be important if Bezremi is able to get a approval in ET. That means physicians can prescribe it. That means it goes better into the guidelines. It means that there is additional kind of company support for patients needing things, patient assistance programs, copay assistance programs. There's just a whole range of things that flow from something being approved.
Dr. Mesa and Dr. Pemmaraju, I do have a question. You mentioned a couple things that I just want to interject. When you talk about blind studies, some of our patients, I know there's been some activity out there in the advocacy world about, when a person decides to, or when a person is approved to be in a trial, and then they're given placebo, and how that just doesn't go well with them. And can you talk a little bit about that? Naveen, do you want to start, and then Ruben add your thought?
This is something that is of high importance, to Ruben, myself, and the investigators in the field. I think this is a very important topic, and I'm glad you asked it. I guess kind of two things I'll say to start our discussion off is, I think it just goes, number one is, and you're right, it comes down to informed consent. Let me emphasize the word informed. Oftentimes, consent has historically, sometimes, not everyone, but a lot of times, busy office practice, clinical trial, let's get moving, let's give someone a 50-page document, and can you sign this right now? Thank you very much. Nobody's going to go home, read that, and process that. I just, exactly what you're saying. So I think we need to put the informed back in informed consent. There has to be a more streamlined process. Instead of a 50-page document, actually a lot of this can be explained in 2 or 3 pages. There needs to be a real discussion about what a clinical trial is, not only in medical terms, but in layman's terms. And then, yes, if there is a placebo-controlled arm, blinded arm, what does that mean? What are the implications? And people need to not just know about it, but the family member, the spouse, the caregiver. And then finally, there needs to be some time and space to process in a non-emergent situation. So I think we as leaders, physicians, healthcare providers, pharmacists, it's not just that we can do a better job, we need to do it in a whole different way. And so I think that's part one. But part two, I think that research at the highest levels still does need the placebo-controlled blinded study, mainly because we're in this field where we have oral medications, we have diseases and outcomes that may take years and years and years to find. And if we want to prove to ourselves sometimes what we would call a gold standard, I think it is still appropriate and okay, as long as the patient knows what they're getting into, they know what their options are, is there a crossover allowed, can I get off the study, et cetera, et cetera. So really reimagining, I would say, the informed consent process in a way that makes sense to everyone, that's still efficient, that still gets the message across, and then making sure that people know they have options. If you get randomized to the placebo arm, here are your options. X amount of people are going to cross over. You can come off the study at any time. That's your right. We can monitor you. So I don't want people to feel that they're being experimented on, but rather that they're a partner in the process. And that if they're helping out, being in a research trial for themselves, their family, or for other folks, they know what they're getting into. But Ruben, boy, I would love to hear your thoughts on this. This is a frequent conversation for us.
I've had this conversation directly with the leadership at the FDA,
Mhm.
and I've just been appointed to a group. There's the Clinical Trial Advisory Committee for the National Cancer Institute. So it's an overall stewardship group for all of the cancer clinical trials in the United States. And so one, I agree, a placebo study they are the vast minority. So there are very few of our studies that are placebo studies at the moment. They are truly in the situation where the alternative option is nothing. So let me give an example. If we were to have a 40-year-old patient who normally gets phlebotomy and aspirin with P-Vera, and we were trying to use a new drug X, see if, again, there's some way that it's maybe different than how we normally treat it. It may not be unreasonable to say, one group gets phlebotomy, aspirin plus placebo, and one group gets phlebotomy, aspirin plus drug X, because we wouldn't normally be using another drug in that situation. So that's a little bit of the origin of that, where the alternative is nothing. Frequently, studies like this will have people only be with placebo for a period of time and then switch to the other active drug. There are times as well that we will use a placebo in addition to an active drug. So let's say, for example, if we're asking a question of adding a second drug to ruxolitinib, and we compare the current standard, which would be patients receive ruxolitinib, and the comparator is ruxolitinib plus drug X. Let's say the comparator is, let's not even call it a drug, ruxolitinib plus you eat 2 bananas per day. One group gets the 2 bananas, the other group gets 2 fake bananas. And you see, did really having the banana, does it really make a difference? So at sometimes, again, just to kind of prove that there's a difference.
Yeah.
But I think what we really, really try to avoid is where somebody should really have an active drug and they're not getting anything. And that usually is not the case.
That's right.
So we're not going to say someone needs treatment and they're not going to get treatment. So it could sometimes be part of something and not be as kind of unreasonable as it sounds.
But how does that happen, Ruben? So let's say, and pardon my naivete here, but let's say that I'm in a trial and there is a placebo arm, but all of us have gone through the same criteria. We've all met with the same criteria. So how do you discern who should be getting the active drug and who shouldn't? Or how does that work?
So normally this would only be an issue in the studies usually that we call the phase 3 studies, where we're really trying to compare two things. And it's usually in a situation where we have, one of the drugs, where both treatments are active. The placebo is just kind of part of it, or a best alternative therapy, or things of that nature. Now, before we have anything, we don't have anything. So for the original studies that got ruxolitinib approved, before there was anything that was approved for myelofibrosis, the comparator was placebo. But there really hasn't been kind of a placebo control since, because we have ruxolitinib. So it continues to evolve in that way.
Okay.
So let me finish this up with ET, because I know our time goes quickly and many drugs for us to discuss. But in ET, so some other important kind of short-term and long-term things. So first, in the short term, there are trials both at my center, but others for other drugs in investigation. Now, the list in ET tends to be shorter. By far, the shortest list of drugs being tested are in ET and PV, even though that's the largest number of patients. So why is that? In part, because we want to be pretty sure that a drug is safe and effective before we try it in patients with ET and PV, they have earlier disease. They really have, you know, we want to be sure and protect individuals whose health is otherwise, you know, good. So it's from a safety perspective. And by far the greatest number of drugs tested in myelofibrosis, even though that's the smallest number of patients, because the disease they face is the most severe and the unmet need is the most significant. So in ET, the additional drugs include IMG 7289 or bomedemstat. These names are complex, but this is working at the bone marrow level. It looks to control platelets in patients that have failed hydrea, in addition to having an effect on the underlying biology of the disease. There was data presented at the American Society of Hematology in December with the initial study showing that, again, it's active in individuals, some individuals that have failed multiple drugs. We have a parallel study with the same agent at our institution. Again, many are individuals who have failed all of the other drugs. They've tried hydrea, interferon, anagrelide, even ruxolitinib, and they've either had side effects or it was ineffective in controlling the counts or things of that nature. Now, ET is an area where, again, new trials are likely going to be forthcoming, and some of them may be directed. These are future state, but directed against things like calreticulin with vaccines, cellular-based therapies, or other things. So Naveen, maybe just share with folks a little bit. These are not yet quite ready for prime time, but there are, you know, both drugs that we talk about in MF may evolve to be tested in ET, but also there may be other approaches that may evolve.
Yeah, that's right, Ruben. And I think, you know, for folks out there, you know, we can get a list of names of all these drugs. I think some of these names are just so long and confusing and they have letters and numbers. So definitely want to send a shout out to everyone out there. But, you know, what Ruben is saying, it really is important, which is that you are informed in really kind of three ways with these chronic MPNs, so ET and PV. One is from the science itself, so over time, right? So calreticulin or CALR, C-A-L-R, we only knew about that since 2013. That's when the presentations were at ASH and New England Journal that day. So that's less than 10 years. And then, you know, other new pathways that come up. Ruben mentioned, we both mentioned this LSD1 pathway or the bromodomain pathway. These are new pathways that are being elucidated, you know, in the last 10 years. So molecular pathway science. Number two, you're informed by drugs that you use in the other diseases, myelofibrosis in particular, more advanced diseases, and then you bring them into the earlier MPNs. And then number three is you have the historical experience, which is Dr. Silver, our great friend, mentor, and colleague in New York, who's been using interferon, you know, at least since the 1980s. And so you have the new formulations of old drugs. So I think the way to summarize ET for our patients out there is what we had before: interferons, hydroxyurea, anagrelide. And then what we're moving towards are the newer formulations of those old drugs. So longer acting anagrelide, different acting interferon. And then the third category are the brand new pathways: bromodomain inhibitor, LSD1 inhibitor, et cetera. So maybe the names, I think, Anne, are not as important as just kind of the concepts. And I really love what Ruben said. You have to make sure about the toxicity and the side effect profile for our patients. And all of these studies are incorporating Ruben's MPN symptom burden scale. So that's a way to quantify, so to make objective the subjective. So not only we want you to improve from your ET, but we want your symptoms to be better. We want you to have less blood clots, less bleeding, and ultimately a less chance to transform to myelofibrosis or acute leukemia. And so that window, that bar that Ruben was talking about, especially in ET, we have to find that right balance.
So fantastic. So let's pivot to PV next.
Yeah.
PV, a prime example. So we talk about, you know, what's our base, you know, and our base with PV has been historically, you know, everyone gets control of the hematocrit under 45% or less. You know, maybe some minor modifications if you live at high altitude or Some individuals may feel better at a little bit lower level. There's, perhaps some female patients may be a little bit better off at a little lower levels, but roughly control of the hematocrit, and in most situations, a baby aspirin. And that individuals that didn't tolerate phlebotomies, had strong cardiac risks, were older than 60, had prior blood clotting events, were on a medicine to try to control their counts, with that being either, again, very similar players to what we had heard, but with a couple important modifications. So interferon, and here again, now we've got the new approved ropegolate interferon that can be used as frontline treatment. We've used pegolate interferon alpha 2A, and there's very good data behind that. There's no data comparing those two for those that will ask that as a natural question. Hydroxyurea, again, can be used. I think many will prefer interferon, but hydroxyurea can benefit a range of folks, and there's good reasons to use it. And then we have the approved ruxolitinib, now along with the ropeg. Those are the two approved options. So ruxolitinib is approved in the second line setting, particularly helpful for people that have failed hydroxyurea, have difficult symptoms, have enlarging spleen, and difficulties of that nature. So one area of investigation that is an interesting one are a new class of drugs that are called hepcidin agonists that may somewhat upend that traditional way we've treated PV, to ask the question, well, phlebotomies can have some negative. They're uncomfortable, they're a hassle. The hematocrit is always going up and down. If it goes up, you get a phlebotomy, it goes down. It climbs up again, you get another phlebotomy. There can be symptoms. Patients who tell me they're lightheaded for 2 days after they get a phlebotomy. It can, be very hard on your arms in terms of, getting the phlebotomies drawn. If I tell Naveen he needs a phlebotomy tomorrow, he's got to cancel his morning clinic and find a time to get that done. And, so there are some real negatives to it. So there's some drugs that, again, asking the question, can we help make you phlebotomy independent? Naveen, want to walk them through what is hepcidin, and where do new drugs such as PTG 300 fit in that mix?
Yeah, what a great overview. And so now that's where we were, that's where we are. The new agent that Ruben mentions is called PTG 300 as the code name, or rusfertide, RUSFERTID, rusfertide. So this is the science that Ruben is talking about. So as our patients know, and as Ruben and I know for you, getting a phlebotomy is not a benign process. It is a half a day for some folks. You got to get to the center, you've got to get your blood drawn, you've got to wait there, you've got to make sure you're okay after. And during a pandemic, during a time where you want to minimize your interface, this is the one thing that Ruben and I have not figured out how to do virtually yet, okay? So this is another chance that you have to come and be exposed. So the question is, can you normalize the body's iron stores? Because after all, you need iron to make blood. And if you have polycythemia vera, you have too much circulating iron that's not going into the right space. So that's the question that was asked. So our colleagues, particularly led in New York by Dr. Ron Hoffman and his team, have been really working on this question actually for decades. And it turns out there's a pathway or a molecule, hepcidin, which basically is trying to tell the body to be at homeostasis or balance with its iron stores in the liver, in the blood, and all these areas. Polycythemia vera, this pathway is disrupted, and the new drug is trying to restore that balance. And so with this rusfertide PTG 300, which I've been a part of this study, pretty encouraging, very nice results so far in what we call the phase 2 study. So these are patients, Anne, who've either had hydroxyurea, or they can actually still be on their drug and then get the rusfertide. It's a weekly injectable, so once a week. Interestingly, right, a lot of Pegasus interferon is also a weekly injectable. So that's something that's known in our field. And the goal here is, can you provide, if you will, if you'll allow me to say, more like a continuous phlebotomy rather than having to come at random intervals. If we know that the hematocrit below 45 is the way to go, but you're only checking it once a month, once every 3 months, well, as Ruben mentioned, it may be going up and down during that time. So once a week injectable. We've shown the data now publicly, updated again at the ASH meeting, that shows that a quite high amount, almost all the patients who are getting the weekly injectable are having restoration of their hematocrit levels, so below 45, becoming phlebotomy independent, staying that way, and then maybe in some of these patients, they're starting to have what's called symptom benefit, right? Again, this Dr. Mesa's scale where we can measure if you're feeling better from your disease. So the big news that everyone should know is because of these encouraging early results, this PTG 300 or rusfertide is now going into what's called the phase 3 testing, a big study across the United States and the world to be able to tell once and for all if this agent is benefiting patients. And obviously, if it does, then it can be considered for regulatory approval after that. So this is the drug that Ruben is talking about, rusfertide, PTG 300, hepcidin mimetic, which is the new kid on the block in polycythemia vera.
Excellent.
That's a wonderful overview. So
Very good.
It's an active, ongoing, accruing study, and there are other drugs in development, kind of in this same vein, that are looking at that pathway in slightly different ways. So Ionis, that's similar. It's going to be opening up a trial, really kind of looking at the same pathway. But it's interesting and it's exciting to see kind of new approaches in P. vera as well. Now, there's a couple of questions in the chat. Maybe I'll just try to summarize a couple in terms of, what does it mean to fail hydrea? And one question that says, since we know interferon might have an impact on fibrosis, is hydroxyurea really no longer appropriate to give? Is it the wrong therapy? So first, as I try to describe hydroxyurea overall, it's a therapy where the strongest benefits we see in terms of evidence, medical evidence, is in ET, little less in PV, and by far the least in myelofibrosis. And it is true that our long-term data from rho-pegylated interferon suggests that there are subsets of people that can have a decrease in fibrosis, and overall, there may be more of a decrease in the allele burden for patients taking pegylated interferon versus hydroxyurea. So these are two things that say, kind of in a broader group, maybe some additional benefits, that people may experience. There's no guarantee that occurs in each individual, and there are reasons we sometimes choose one drug over the other. Interferons are good, but they can have their own side effects. They can cause depression, sometimes can cause autoimmune disorders. There are some people that have taken them and they just don't feel well on them. So again, I do think interferon continues to make a case to potentially be a stronger starting place for some individuals, but maybe not for all. And hydroxyurea still can be very helpful for some individuals that took interferon and it was not that helpful, or they had side effects or other difficulties.
So another question I just want to ask real quickly, and that is, we've known patients that have been on interferon and actually went into remission. In fact, I spoke with one yesterday who was on interferon for 3 years on Pegasus, and no signs of the disease right now or the cancer right now. And so can either of you speak to that a little bit? Because in one patient that I think all three of us know pretty well, she was a patient of Dr. Silver's and did very well on interferon and was in remission for, I think, 10 years. And then after a second child, got very sick with PV. Can you, either of you, give your opinion or your thoughts about that? What happens after you've been in remission? That's something, that something else happens, that the disease comes back. Naveen?
Yeah, I think this is a very important point. We think about disease progression in kind of three ways, and you kind of nicely laid it out there. One is the so-called long-term responder, which is of interest to a lot of our folks out there. So you're having a long-term response, and then something else factors in, heart attack, stroke, pregnancy, some other event. Number two is the long-term responder who truly really has disease resistance. So a biological, scientific change of the disease where it's now aggressive and active. That's similar to, a virus or a bacterial infection, maybe using that analogy. And then, of course, there is that sort of third bucket, which is the disease is going well, the disease process and the treatment, but you're having toxicity, you're not able to stay on that medicine for whatever reason. And so now either because of impartial not impartial treatment or toxicity, now you're not able to take the drug and then the disease rises up. So let's tackle that. I think in P. vera, for example, what we mainly see is people having breakthrough symptoms. So you're on a stable dose of Pegasus, or like you said, life issues, you have to come off. And you didn't realize how much the interferon or the drug was keeping the symptoms at check, the fatigue, the bone pain, neuropathy, whatever you're having. So I think there is a bit of a withdrawal or rebound, based on symptom burden. So that can be addressed by either reintroducing the drug or going to another agent. Number two is actual disease progression. I mean, that's something we have to really think about. And that is a serious issue. That means that your disease that was being treated is now revved up and is going in a different direction. So you do have the Jakafi, for example, the ruxolitinib, specifically approved for at least post-hydroxyurea PV. And then the third issue is toxicity. You're having unbelievable toxicity, but a good response. Well, that drug doesn't work, for you. And so that's where the other agents or clinical trials come in. The last point is that these diseases can change over time. From the time of William Damashek in the 50s and 60s through Dr. Silver's time and now through Ruben and I in our era and beyond, these diseases can change form. And so anytime that there's a question, a major change in the disease or the patient, sometimes you just have to stop and reevaluate, whether that's a bone marrow biopsy, blood count checks, to see if the P. vera is still P. vera, or is it now going to myelofibrosis, acute leukemia? So always think about, hey, do we need to pause and reassess the disease process itself? And then one last item, a lot of our patients live into their 70s, 80s, 90s, et cetera. And so sometimes there may be other processes going on. I really love that you mentioned that. So you need to be thinking about other things. Are you getting your cancer prevention checks? If you have bleeding, are you checking to see if it's colon cancer? So don't forget about primary preventative care, thinking outside of the MPN, thinking if the MPN is changing. I don't know. I guess that's my general kind of feedback in these tough cases.
Very helpful. Well, I know our time is moving quickly.
And we have a slew of questions, but I know you wanted to show a slide and go
Sure.
over.
Well, let me tackle one of them because I think that this is probably on many people's minds, but then we'll pivot to myelofibrosis. So I have a slide that helps to kind of encapsulate what's really kind of almost a river of different studies going on in parallel. But there's one question kind of comparing Besremi or ropegalated interferon alpha 2b and Pegasus. And I'm sure this is on many people's minds. So these two drugs are fundamentally, when we talk about interferon, they're both, quote, interferon. They're both long acting. A big difference is that ropegalated interferon is FDA approved. So that probably has real implications in terms of its support, in terms of its production, in terms of it potentially being covered by your insurance company and other pieces. It's dosed every 2 weeks. It is in some ways there are, when medicines occur, there sometimes are slight variations in the molecule in the medicine. And the ropeg is a pure single molecule. Pegasus is a bit more of a mix. You could think of a wine that is either all of one grape or like a blended wine. This is kind of, this is like a pure cab. It's just one. In short, people that are doing beautifully on Pegasus right now, it's not necessarily clear that there's a strong reason to change. You're getting it covered, you're doing well. I think that may evolve over time. I think people that have not been on interferon at all, I am putting new patients on Ropeg. It's approved. It doesn't make any sense to do it the other way. People that are on Pegasus but are having side effects, again, maybe a discussion with your doctor, or if you're switching from Hydroxyurea to something else. So I suspect, without Pegasus having an approval, it will slowly continue to evolve toward being more dominated by Ropeg. And clearly, new patients, if you're going to start something, you may as well start on Ropeg. But there's not a dramatic difference in terms of the molecules themselves. So let's pivot to MF. Naveen, why don't you just give them a sense while I pull up the slide about various experimental things. But first, on just a thumbnail, as we stand at the moment, we just have Rux and fedratinib, although that may change even in the next month or two.
Right. So as Ruben mentioned, we want to give everyone out there the base first before we give you the letters and numbers, new things. So just to remind everyone where we are in myelofibrosis, the three principles are that we want to stratify your disease by low risk, intermediate, high risk. So if you are intermediate to high risk, we have the one approved class called JAK inhibitors. The first one was the ruxolitinib or Jakafi that many of you know. First approved in myelofibrosis, almost now 10 years ago, and now also approved in polycythemia vera after hydroxyurea failure intolerance. So you've got those two approvals in just our MPN space. That agent has been around, tried and tested, and now we have a second drug, fedratinib, which Ruben and our colleagues have also pioneered and now FDA approved. That's been out for 2+ years, just before the pandemic time. Okay, so you have two JAK inhibitors. We have two other ones in the late testing stages, so you should know what those are, pacritinib and momelotinib. So that is in the JAK inhibitor class. And then as I turn it over to Ruben, the two other buckets now for our patients with MF, bucket 2 is combination therapies, which I'll have Ruben give you an overview, which will include a JAK inhibitor plus a new agent. And then, my goodness, a third bucket, Ruben, which is now completely novel new agents beyond JAK inhibitor that you've either had the JAK inhibitor already before or it didn't work for you. And now you're moving into brand new pathways, many of which will be new for our viewers. So Ruben, I'm going to turn it to you. I think you have the slide up here. I can see it clearly. Anne, can you see Ruben's slide?
Yes, I can.
Yeah, Ruben, if you want to take us through some of the new agents.
Sure. Well, first, so just a word or two clearly on pacritinib and momelotinib. So, JAK inhibitors have made a big impact. And as Naveen had said, improved symptoms, improved spleen, patients that are responding to them, there's data suggests people live longer and they live better. Pacritinib may well become approved even as early as next month. Its particular niche is that it can be safe and effective for people with lower platelets. That has been a limiter. May also have benefit in terms of anemia or less anemia. So it's going to have an important role. Momelotinib, we just reported data this week for Serge and I that, again, in the second-line setting, momelotinib used after ruxolitinib helped to improve anemia, spleen, and symptoms in people with the disease. So the JAK inhibitors are very important, and I expect that patients will likely mainly still be on a JAK inhibitor. Alone or in combination, they'll play an important role. Which one in which setting, I think, as they evolve and are approved, that'll continue to evolve, but I think they'll have complementary niches. But what there's been a tremendous amount of work in parallel is thinking about the biology of myelofibrosis. And what you see in this slide, it's complex. People look at it and say, wow, this looks like the Tokyo subway system. There's a lot of different things regarding the biology of myelofibrosis and a lot of thought regarding how we use medicines, whether they be immune medicines, whether they be small molecules, to target aspects of the biology of the disease itself. So let me take one of these as an example. So as cells grow and divide, we have out here, we have therapies that are impacting the process of fibrosis. And some of the drugs that are out there in clinical trials right now, we'll drill down a little bit more specifically, but we have drugs that inhibit fibrosis, such as the drug from Prometeor, that we've shown some benefit in decreasing fibrosis. We have other antibodies that are working against the process of scarring or fibrocytes. We have drugs that are acting on proteins like TGF-beta, of which we have a trial through the MPN Research Consortium with a drug, Avid 200. But let's first, in the interest of time, start on the ones that are most on people's minds in terms of larger studies and ongoing accruing studies. So first, let's talk a little bit about pelabresib, that there's both questions in the chat and study. It's working inside of the cell nucleus, which is kind of the operating system, if I were to use a cell phone analogy, of the individual cells, either alone or largely in combination with a JAK inhibitor. So Naveen, a comment or two on pelabresib?
This is an awesome slide, Ruben. Thank you. Yeah, so quick comment on each of these. So pelabresib is a bromodomain, or you see there, BET inhibitor, bromodomain extra-terminal inhibitor. So as Ruben said, you're trying to outsmart or target the myelofibrosis cells at the headquarters in a different way than the JAK inhibitors do. And these are called the manifest studies. And interestingly, what has been seen is that it works in all three of these ways. So as a single agent, the BET inhibitor pelabresib has activity. Now we've seen it have activity in combination when your JAK inhibitor isn't working so well, and so you add it in as a second. And then now we're moving it into the frontline combination in the ongoing phase 3 study. Brand new diagnosis of myelofibrosis, you qualify for the trial, ruxolitinib and pelabresib together. And the goal there is, would the two drugs be better just than the one drug by itself? That's the ongoing question that we're asking, Ruben.
Very helpful. So you'll see here several names that you see that are in ongoing studies. Pelabresib that's being tested in a range of ways. And again, it's looking to have an impact on an aspect in the nucleus that we think is relevant to the disease in combination with JAK inhibition. Bomedemstat, which we had mentioned in ET, again, is working in the nucleus in a slightly different way, but again, trying to get at the biology of the disease. And in myelofibrosis, studies ongoing. Kristen Pettin and others have reported on these from our friends at Imago, again, looking at this single agent after ruxolitinib. Imetelstat, similarly, again, the nucleus is very important. That's where you see a bunch of these drugs kind of living in the nucleus. Here, trying to have an impact on an important enzyme called telomerase involved with the aging process and the formation of chromosomes and telomeres. That is in an ongoing study after patients have been on ruxolitinib to see impact. So all having impacts in different aspects of this. Another ongoing important study is the drug from the company called AbbVie that works in a different part of the process of how cells grow and age and can die, called apoptosis. This is a drug called navitoclax. Naveen, want to comment to them a little bit about navitoclax, why this is active and what we've seen so far?
Yeah, the overview here, Ruben, is that in many of our blood cancers, we've seen the cousin drug, venetoclax. Many of you may have heard of that drug, highly active, already approved in a number of different blood cancers. That primarily hits the one on the left called BCL2. But the navitoclax really hits mostly the one on the right called BCL-XL. And for whatever reason, in the lab, we found that myelofibrosis, our disease here, really kind of depends on that BCL-XL pathway. That's new science only in the last 5 years. So this agent, navitoclax, not yet FDA approved for any indication, is in the clinical trials, and it is showing in the early results I showed at our national meetings publicly that when you combine that drug with the ruxolitinib in this strategy 2 that we've been talking about, the combination strategy, we are showing that it is early on. Spleens are decreasing in patients where the ruxolitinib alone may not have been working as well, and symptom burden is improving. So now the task at hand is we have that early positive signal. And so the theme that you're hearing today that's new for a lot of people, this also, just like the bromodomain story and the imetelstat story, is now in phase 3 testing, Transform 1 and 2 trials, globally open, ready to accrue for patients, and asking the same question: can the combination of this BCL-XL inhibitor in combination with JAK inhibitor be better for our patients than just the one drug alone? So stay tuned for that. Those data are, still being generated. As with any drugs, you have to watch for new toxicity, new side effects with all these. So we have to watch the platelet count levels, for example, with many of these new drugs. So Ruben, so that's another one that you're showing, and I love this slide, that's actually heading into the phase 3 late stage testing.
So a huge shout out to amazingly talented colleague Doug Tremblay, who put this slide together for a paper that we put out regarding new options in myelofibrosis that'll be coming to a journal near you sometime soon. But lovely job,
Very nice.
as well as the illustrators at the Sinai that put this together. So a couple of things before we maybe close, just talking about, how do you get on a study? When do you consider it? Things of this nature to demystify it a bit. But we've got, as things evolve, we have many drugs because not everyone has the same myelofibrosis. You guys are not all the same. I have a patient yesterday who I saw on our MPN Research Consortium study who has a specific genetic change in IDH2. We now have an IDH2 inhibitor. This individual has had a beautiful response. She's got this mutation. She got the drug that blocks that mutation and a JAK inhibitor, and had a much better response than she was having with Rux alone. So that's an ongoing study, but again, a very specific group. You got to have this mutation, of which is only in a small subset of people. Some other key drugs on here: parsaclisib, a PI3 kinase inhibitor. There's more than one PI3 kinase inhibitor in development. Multiple different MDM2 inhibitors that are, again, in important ongoing studies from Kartos and others. Tegrascofusp, a very important drug that Naveen has been working to develop and got approved in a different indication. Maybe final drug highlight before we talk a little bit about going on a study. Naveen, a word or two about Tegrascofusp.
Yes, sir, Ruben, that's right. So as Ruben knows, I've been working on this drug for the last 10 years. We did get it to FDA approval here in the States for a very, very rare leukemia known as blastic plasmacytoid dendritic cell neoplasm, or BPDCN. So it is US FDA approved in that rare indication. But the target, CD123, is on the surface of a lot of our blood cancer cells, including, it turns out, MF. And so that surface marker, CD123, it serves as an antenna on the cancer cells. And our hypothesis is if we can target that, it may help our patients with MF. We have now completed, and we showed data last month at the ASH meeting in the phase 2 with this drug, Tegrascofusp, or now TAG, maybe easier to say, that it has encouraging modest activity as a single agent in patients with myelofibrosis who already had, and the ruxolitinib did not work. So now we need to continue to follow this story in this myelofibrosis and in the other blood cancers, CMML. So the last concept here is that a lot of these drugs are new age drugs. This is a diphtheria toxin that's modified, fused to what's called protein IL-3, and then that's then deposited in the cells, leading to this apoptosis or cell death. So Ruben, I think you nicely have kind of given us an overview of these drugs. They're not just pills anymore. These are IV drugs. It may require some hospitalization. You have to watch out for side effects. So we're entering a new era in our myelofibrosis patient care. And this, your overview has given us a way to really think about that new era over the next 5 years, Ruben.
So I think a few kind of key closing comments. First, be hopeful because of surely the number of these things that are being developed, tested in parallel. 2, don't feel, and I know it's easier said than done, don't feel overwhelmed by kind of the volume of what's going on. All of this kind of is occurring in parallel, which is good. And those that are the most effective will surface and become options for everyone. So people say, well, I want to participate in every study. These are things, it's best they really need to kind of work through their path. Now, who should go on a study? I think this is the most important part. If you are currently on a treatment and doing well, it is best to remain on the treatment likely that you're on and let this process evolve. The best situation is you're stable and we need to change you to a new therapy because we know that it's better without you becoming worse. Because for the most part, what makes individuals eligible to participate in a study is that they need a different treatment because the treatment that they are on is not working. Now, there are a couple important exceptions. There's a couple of trials in here that are, again, in people that have not been treated yet, but are just going to start a treatment. So that's where those combination frontline studies are a little different. The vast majority, I'll say 95% of the myelofibrosis studies are in people that have been on ruxolitinib or fedratinib and have a suboptimal response and either get a different treatment or something else is added on. But there's a small number. I've just been diagnosed, I've not been on Rux yet. There might be a trial of Rux plus pelabresib or Rux plus navitoclax or Rux plus parsaclisib that may be different. The key is that your healthcare provider, your hematologist, is kind of your portal to discuss, is there a trial that I'm a candidate for? Does it make sense at this moment in time? Or sometimes if they don't really know, Anne and her team at MPN Advocacy and Education International might be able to assist. Or there are other resources you could tap into, Leukemia and Lymphoma Society, MPN Research Foundation, or others. Naveen, any final comments before we close on trying to be hopeful, but not overwhelmed by all of this information?
Right. Well, you just inspired me, as you always do, my friend. And thanks to Anne and her team. I think you hit on it. I think the two things that Ruben and I have always talked about and we want to share with you is, number one is in a rare disease like these MPNs, where it may only affect 4 to 5 out of 100,000, just know that you're not alone. Just because it's a rare disease to the greater world or the greater community, it's not rare to Ruben and me. It's not rare to you and your family, your spouse, your caregiver. It's your disease. It's your journey. It's what you're facing. So what you should get out of this is that no matter how common or rare a disease is, there's probably a lot of research going on in that area, as we showed you a sampling, and now we're all starting to talk together. And then two, despite the COVID pandemic, which has been one of the most awful things of our adult lives, the research is actually exploding and continuing. And I find that to be miraculous. The communication is continuing through social media, online, video conferences, meetings like this. So you should have a lot of hope and optimism, at least that the process is moving forward. And so this hour-long seminar should give you just a sampling. In fact, we didn't even have time to show you some of the scientific breakthroughs and others. So I also leave you with the message of hope and optimism as we go into the third year of this pandemic, that there's someone out there working on your disease, working on trying to make your life better. And I think that we're all starting to talk together, share those findings, and communicate despite the obvious barriers with travel. Anne?
Well, I can't thank both of you enough, as always. And this was so informative, so very informative. And I echo what both of you have said completely. That, I always say the earth is moving under the MPN world, always. It just never stops. And it is so remarkable to me, given that we're in this third year of the pandemic. So we will host other events like this because this was brilliant. I loved it. And I hope that the individuals that were with us today felt the same way. We weren't able to get to all the questions, but we will try to get answers to those questions that we have, and we will host something else very soon. We are hosting 3 actually focus groups with patients that have been in trials, patients that are in trials, and patients that want to be in trials. And I'm very hopeful that those folks that were with us today, because they would have learned quite a bit here. But we can always learn from the patient's perspective as well, who, God love them that participate in these trials. It's just, phenomenal to me. But thank you again. I know it takes time out of your busy schedules, and God love you both, and stay safe.
Bye-bye, and thank you.
Bye. Thank you, Anne.
Bye.